is the Aspergillosis Trust. We are talking about aspergillosis together with Darius. My name is Bart. I'm a ABPA patient, and I'm also a member of the Aspergillosis Trust. Very happy to have Darius Armstrong here. Do you want to introduce yourself?
Thanks, Bart. Yeah, thank you for inviting me. My name's Darius Armstrong James. I'm a reader in infectious diseases and medical mycology at Imperial College London, where I run a big research lab looking at why people get aspergillosis and how we can improve diagnosis and treatments. And in addition, with Anand Shah, I co-run the Royal Brompton Fungal Disease Service, where we basically treat many patients with aspergillosis through the NHS in central London.
Fantastic. So last time we spoke, we sort of talked about the journey from you're not feeling well up to a diagnosis, right? We covered that. I think now we want to go a little bit further, which is help us understand this a bit further, and then also have some insight into how this would evolve. So let's start with the beginning.
Yeah.
What is aspergillosis?
So, I mean, aspergillosis is mainly a lung infection. You can, I mean, in other parts of the world, it causes lots of eye infections, especially in people who are processing, grains and wheat. But in essence, in the UK setting, it's mainly a lung infection. It's caused by a mold, mainly the mold Aspergillus fumigatus, although there are other kinds of Aspergillus that may be prevalent in other kinds of the world. For instance, Aspergillus flavus or Aspergillus niger and Aspergillus terreus. Those can also cause infection, but probably 90 to 95% is caused by Aspergillus fumigatus. Aspergillus fumigatus is actually a green mold, so it's a kind of fungus. And this fungus is very common in the environment. It lives in the soil and is involved in decomposing rotting matter. So it's one of the main things that decomposes rotting matter and basically helps make soil and things like that. Essentially, the reason it's so successful in terms of causing infections in the lung is because it releases many spores into the air. And these spores are very small. They're small enough that they can get right down into the bottom of the lung airways and cause infections. So we're all continuously inhaling these spores. And actually, I think it's a miracle that more people don't get aspergillus. It's a testament to evolution that the immune system in the lung is able to clear out, 100 to 1,000 spores of this organism every day without causing infection in most people. So why do people get it? I guess we're all inhaling it, so we're all constantly exposed. And then if something goes wrong in terms of lung defenses, then you can develop it. And in terms of what can go wrong, either developing a chronic lung disease or receiving a drug that weakens the immune system or having another reason to weaken your immune system are the principal reasons.
So if I would ask them, if I would say, well, why me? Why do I get this? Then your answer would be, well, you have asthma, so you're likely to get this.
Correct.
Is my understanding also right that there has been some DNA research that?
Yeah, there has been some DNA research, and across all the different forms of aspergillosis, there are a number of different genetic reasons. The strongest one is something called chronic granulomatous disorder. That is what we call a primary immunodeficiency, so something that you're born with. And those patients, they get very severe aspergillus from an early age. And the reason why is because the immune cells in their lungs aren't able to kill aspergillus directly. So that's a typical one. But in things like asthma, there are certain what we call polymorphisms, which are essentially variations in how genes are formulated, which basically predispose to aspergillus. And almost all of those mutations, or well, not mutations, but they're variations, those are all related to almost all related to the innate immune system, by which I mean the part of the immune system that's responsible for day-to-day clearance of organisms from the lung, so the patrolling cells in the lung.
Okay, thank you for that. And I of course, DNA, I hope we can reprogram this so that we can do something about that. Another question that I think is very common is, oh, I have aspergillosis, and then I look a bit further, and I have I see all these types of aspergillosis. It's like an alphabet soup: CPA, ABPA.
Yeah,
Can you
correct.
sort of talk quickly about the biggest groups there? What does that all mean?
So I think it's one of those issues we have in the field, which is useful and yet confusing, because actually, if you look at Aspergillus, what we see is what we call a spectrum of disease. And the reason we see a spectrum of disease is because fungi are really unique in that they can cause infection, but they can cause allergy. And Aspergillus is a very good example of that. And so you have some people, for instance, if you have a predisposition to allergies, like people with asthma, who when they get an infection with Aspergillus, the main manifestation is an allergy. And the worst form of that is called allergic bronchopulmonary aspergillosis. But then there's a spectrum going across to more infection-dominant forms of aspergillosis. And within those, the kind of chronic, sort of less aggressive ones we call chronic pulmonary aspergillosis. And then the most aggressive ones, which are really in people who are receiving immunotherapy or having transplants or chemotherapy, basically we call that invasive pulmonary aspergillosis. So in essence, we've got bogged down with terminology, which is useful to medics, but perhaps less useful to patients, to describe what are effectively sort of discrete categories and definitions within a spectrum of disease, which is a gradual spectrum. It's not like people are compartmentalized. And this does cause a lot of confusion, because there are a lot of people who have, what we call overlap syndromes, or, they're basically not fulfilling all the definitions because they're somewhere outside of these kind of three different areas, essentially. I should mention that, apart from invasive pulmonary aspergillosis, chronic pulmonary aspergillosis, and allergic pulmonary aspergillosis, there's also a really large group of patients who've got what we call severe asthma with fungal sensitization. And that's like a less severe form of ABPA. And the way that we judge severity is based on how many of the different tests are positive and how bad the scans look, essentially. So that's how we categorize it. Does that answer your question?
Yes, I think the main insight, and I actually didn't know that, is that you need to look at it as a spectrum. I didn't know that. I thought there were like absolute differences. That's really helpful. Also, one thing to clear up, when I mentioned to my Canadian friends that I have aspergillosis, they invariably say, "Oh, farmer's disease," and I think that's not farmer's lung. That's not necessarily correct.
No, it's not. So I suppose one thing is that it's quite interesting, but there seems to be less aspergillosis of the chronic forms, i.e. ABPA and CPA, in the United States. And the reasons for that are not clear, but it might relate to the strains that they have being slightly different to ours in the States. So there might be less awareness. Farmer's lung is really interesting because farmer's lung is basically a condition which can be precipitated by Aspergillus or other molds or other antigens that are found within hay, because Aspergillus grows in hay. But it's actually what we call a hypersensitivity pneumonitis, and a hypersensitivity pneumonitis is subtly different to an asthma type response, which is what we see in ABPA. And it's a very different disease clinically in that it can be much more aggressive. We've never been able to show any use for antifungal agents. And the treatment, whilst it does include steroids, can include other immunosuppressing compounds that we don't use in ABPA. So it is clearly a different category. At the Brompton, we're very interested to explore those patients and why their immune system is different to the ABPA patients. And I think that would be very useful to know for obvious reasons.
Yeah, thank you. So I think we kind of covered the definitions and the sort of the groups. But let's go back then as a patient. first consultation with specialists, I think a very common question would be, can this be cured?
Yeah.
And how would you explain then what's going on then?
So I think that is a difficult question to answer, because there's so much, what we call heterogeneity or differences in the different patients we deal with in terms of ABPA. I suppose in terms of aspergillosis, I suppose the other slightly tricky aspect is that at the Brompton we tend to see people who haven't had a response to whatever treatment they've been given locally. So we have very often in medicine, doctors have a kind of sort of tainted viewpoint, because they only see the patients who've got the very severe disease. And I think that is true of the Brompton cohort, and probably also true of the cohort that are seen at the National Aspergillosis Centre. So I think, when we generalise about treatment responses, we always have to be careful that the people who are writing the papers have usually accumulated all of the patients with the most severe forms of the disease, because they're in the big specialist centres. So, there are some caveats there, but in essence, for ABPA, what happens is that in an ideal world, all the guidelines tell us that in the first episode, we treat aggressively with steroids. And if we do that, a proportion of patients should respond and not have ABPA again. However, if they do go on to get second and third episodes, that's when we start looking at other treatments like antifungals and immunomodulators, like the novel monoclonal antibodies omalizumab and mepolizumab that are available for asthma. So there's a number of tools we can use. It tends to be a chronic condition, ABPA, so we don't see huge amounts of complete resolution, but I think we can induce remission quite often in that disease group.
Yeah.
For CPA, generally it depends on how severely damaged the underlying lung is, because in many patients it's causing an infection because there's actually areas of what we call devitalized or dead lung still within the chest, and they're basically the fungus is just colonizing and causing infection in a dead area of lung. And the problem there is that the antifungals can't get into it, so it's very difficult to cure it, but we can stop it getting into the live areas of lung, which of course the patient needs to breathe. So the response rates are usually around sort of 50% essentially, and we're doing lots of work to work out why some people respond and some people don't. In invasive aspergillosis, it's really dependent on how weak the underlying immune system of the patient is. What we know from people who have failure of their immune system that doesn't recover is that invariably the fungus will progress despite the best antifungal treatment. But fortunately, that usually doesn't happen. That's only in a very small percentage of cases. So we know that the patient's immune system is very, very important, as well as the antifungal drugs we use. But by and large, overall, around 70% of people should respond to treatment in invasive aspergillosis.
It's also my understanding that in rare cases, aspergillosis can be removed, or
yes.
Can be removed.
So the surgery to remove aspergillus is something that we usually try to consider, because we know that it can be effective. The difficulty is that it's probably only appropriate where someone has quite localized disease, i.e. it's not affecting the whole lung. So usually in ABPA, we probably wouldn't go down that route, because we know that it comes and goes and it can affect both lungs throughout both lungs, and that you may resect one bit and then the next month another bit comes up somewhere else. So we wouldn't do it in ABPA, but in the infective forms of aspergillus, in particular in chronic pulmonary aspergillosis, if we think the patient can tolerate it and it's well localized, we would consider it. But we would always go with the antifungals first, because they're less harmful than surgery, less dangerous. And of course, many people won't be fit enough to have surgery if they have severe respiratory problems in the first place. And the other reasons that it might not be possible are either because they have a lot of abnormalities with the blood supply to the area that's affected, or if the fungus is affecting the lining of the lung, it can be very difficult to remove.
Thank you. So, and I think another question that I think when people talk about lung problems, they might think about lung cancer, and you know, which is a very, unfortunately, high mortality. So, if patients would ask you, like, they're diagnosed, say, well, is that it? Am I going to die within, you know, a short span? And of course, I realize you see a wide variety of patients, but how would you approach that?
So yeah, I mean, in terms of Aspergillus, in most cases, you know, we don't expect people to die quickly from Aspergillus. We expect that the treatments that we give can help them, basically. Certainly within the context of CPA, I mean, there was quite a good study to show that probably it's more the underlying disease that they have than the Aspergillus itself, which is more likely to cause problems. And I think that, you know, the fungus itself killing you, I think in our practice, mostly not. You know, for most people, we can do things. We try, you know, we work very hard. This is what we do to stop the fungus progressing. So, you know, there is a risk, you know, in patients who've got very big problems with the blood supply, that they can have severe hemoptysis, i.e. coughing up blood, and that is a concern. But I think for the chronic pulmonary aspergillosis and the ABPA, in most cases, you know, we can do something in the majority of cases, and we can slow the fungus down. In the invasive disease, I think it's quite difficult. We know that the attributable mortality from IPA is probably somewhere between 20 and 30%.
Yeah.
And by and large, that's because what is happening is that someone who's got, you know, whatever underlying condition they have, you know, a bone marrow cancer or whatever, their immune system has actually failed. And so they, you know, the fact you can't live without your immune system means you'll die of Aspergillus or something else. So you know, the mortality is higher there, but the drugs are improving all the time. So,
thank you. That's also the impression that I have, that it's not stable. I think that's one thing I would like to talk about that. But largely, via the trust, I know a lot of people now who have aspergillosis, and the drugs clearly work. Like the profile of the drugs changes from person to person, how you react to that.
correct.
But you keep going, assuming you obviously many people have other health issues. One thing that I personally struggle with, that it's not stable. Is that something you see? So it changes from year to year, not always for the worse, sometimes for the better. And is that something you see frequently as well?
We see that as well, and I think, you know, this is a very I want to say interesting, but I should never say interesting, you know, with patients, because it's not interesting, it's a serious issue. But basically, the issue is that in ABPA in particular, we don't understand why it comes and goes. So when I see an ABPA patient, there are three things I'm trying to deal with. Firstly, controlling their asthma, right? Because most of them have got asthma, 99% have asthma, or cystic fibrosis as well, of course. But for those who have asthma, I'm looking to control the asthmatic side of things, because that can cause wheezing in particular and breathlessness. Secondly, I'm trying to control the fungus, which may be causing an infection. And so, you know, I'm thinking about antifungals. And thirdly, I'm trying to account for any potential other bacterial infection that could be causing a problem. So when an ABPA patient has a problem with their breathing, it could be any one of those three different things. The job of the doctor is to work out which, and then target it appropriately. And within that, the intrinsic nature of the fungus is that it does seem to wax and wane, and we don't understand why. And you know, we're just discussing at the moment that it would be nice to do some studies to try to work that out and why it's happening. It's a phenomenon we see in many different chronic respiratory diseases, you know, irrespective of Aspergillus. So that is interesting. and something that would be really nice to understand better. In CPA, yeah, I mean the fungus does wax and wane. It's actually noteworthy that when we do the scans in CPA, the cavities can get bigger and smaller, and the amount of fungal ball within them, or mycetoma or aspergilloma, can get bigger and smaller. But we don't actually think either of those appearances are in any way telling us anything about whether or not the disease is getting worse or not. The main thing that's telling us about whether the disease is getting worse is how thick the rim of the cavity is, where the CPA is. So we worry in particular if that cavity is getting thicker. And those patients can get lots of bacterial infections as well, of course. So, that, and they have their underlying diseases like sarcoid or COPD. So there's quite a lot of different reasons why things can go up and down for these patients.
That helps a lot, actually. It's clear to everybody who has this disease that medication works in different structures. It depends on the person, and so forth and so forth. But I'd like to talk very quickly about outside of medication. What guidance would you give in terms of behaviors for patients or for non-medical approach that they can take that would be helpful?
So yeah, I think this is probably the primary thing is around respiratory health. So in particular for people not to get Aspergillus in the first place, that controlling mold in the home is really, really important. And we know that there are two basic principles about stopping homes getting moldy, and that is that the property should be warm and dry. And part and parcel of that is actually to make sure that homes are well ventilated, because we know that if they're not, that you can get build-up of particular organisms. One organism can overtake the home air. So, ventilation, keeping places warm and dry is important in that regard. There is data to show in ABPA that exposure to mold, in the environment can make it worse and can precipitate it. So, I think if you've got asthma or ABPA, you should be careful about doing things that could lead to a massive mold exposure. And in particular, the thing that you really have to be careful of is composting, because sometimes if compost has been left around, it can generate huge amounts of spores, when you're distributing it. So perhaps wearing, an FFP2 or FFP3 mask if you're gardening would be advisable. We know in sarcoid patients that they can be triggered by molds, and so there is some data there. So basically trying not to inhale too much fungus, I think, is important, although there are lots of complexities to it. For respiratory health in general, I think that avoiding pollution exposure, keeping good weight and muscle mass is really important. Good nutrition is really, really important. Doing physiotherapy, breathing exercises is really, really important, and that kind of specialist training is available within our centres and other centres. So I think those are probably the key things that I would recommend in terms of keeping your health. I think it might also be worth just discussing that for people with infection with Aspergillus, that talking to other health specialists about minimizing immunosuppression or exposure to steroids and things is also quite helpful, because that's something that's not often thought about.
Fantastic. And I think that kind of sort of wraps it up for this episode. Like what we spoke about today is what is Aspergillus? What are the different strains? Where you very helpfully said that it's a continuum. It's not diverse. Some explanation, why it hits some people and not other people. What is the sort of the way forward once you're diagnosed, which is really CPA, ABPA, can be controlled, medically, and do not necessarily have a very high mortality. But look after yourself. Apart from medication, make sure your house is dry, there's no mold. Careful with the compost in particular. I knew that, and then also make sure that your GP is aware of what's going on. With that, I think we're done for this episode. Thank you very much, Darius.
Thank you very much, Bart, and thanks everyone for listening.